Welcome to AETCM, the Emergency Medicine Channel. I am Dr. Rima, first year ER President.
Yeah.
45-year-old, non-case of chronic pancreatitis, type 2 diabetes, presented with complaints of epigastric pain and vomiting into 2 days. Initial 10-second assessment, airway is patent, able to complete one-word sentences, no pooling of secretions or gargling or stridor, breathing, respiratory rate of 20 per minute, saturation of 98% on room air, on auscultation bilateral air entry present. Circulation, heart rate is 94 per minute, BP of 130/80 mmHg and all peripheral pulses palpable. Disability, GCS is 15/15. Pupils are bilaterally equal and reactive to light. GRBS of 124 milligram per DL and pain score of 8/10. Patient was a febrile. Since pain score is 8/10.
So what all? This patient came with epigastric pain and vomiting. Okay. So what all things will you check in a primary survey?
Epigastric pain, if there is radiation of pain.
No, primary survey. Primary survey is only our ABCDE approach. Okay. So airway, as you told, airway patency.
Then breathing rate, any tachypnea or tachycardia, we have to see. Bilateral air entry.
Whatever you told is correct. So, suppose a patient is coming to you with epigastric pain and vomiting, and if the patient is tachypnic, what will you suspect? Very much
Aspiration.
Yeah, aspiration pneumonia can be there. Yes, that usually happens if the patient is having any stroke history, bedridden patients and all. That is correct.
Acute MI can also present.
Yeah, so if the patient has aspirated, there can be any hypoxia related tachypnea will be there. Then what did it? MI, acute MI will be there. There also pain, chest pain might be there. They might present with an epigastric pain. Okay. Then in DK patients will have abdominal pain, vomiting also might be there, and they might be having this Kussmaul's breathing, metabolic acidosis breathing will be. So they can be tachypnic. Or if the patient is having some sort of any sepsis or perforation, that also will cause acidosis, that also will have breathing problems. Similarly, if the patient is having vomiting, abdomen pain, we need to check for the circulation. We will have to check for any bradycardia, hypotension and tachycardia, hypotension, these things. Bradycardia and hypotension is usually seen when?
In spinal shock.
Spinal shock. And also inferior wall MI. Inferior wall MI only will present with epigastric pain. So, inferior wall MI, bradycardia and hypotension will be. If there is tachycardia and hypotension, it can be because of any shock, hypovolemic shock or any septic shock. Okay. So, at this point, any DDs where you were able to make?
It could be a non-case of chronic pancreatitis. So it could be an acute exacerbation of chronic pancreatitis or cholecystitis, or any acute gastritis could also be present.
So we can start either from the skin downwards or from the thoracic region. So we have already discussed about inferior wall MI, or otherwise anything in the thorax that can make the patient have epigastric pain and vomiting. Dissection. That is correct. Dissection. Aortic dissection.
Aortic aneurysm. Abdominal aortic aneurysm.
Okay. Just any lower zone pneumonia, lower zone consolidation. Okay. Then in the skin, any pathology in the skin? Usually that doesn't cause vomiting, like a patient with having herpes and all can also present like the epigastric pain. That is in the abdomen you have told pancreatitis, gastritis, cholecystitis. Okay. Anything else? Then perforation.
Peritonitis.
Then metabolic causes like DK. Okay.
Since pain was 8/10, we started on injection PCM 1 gram and even after that pain was still not residing, so we given injection tramadol. So sample history
How will
for
you give tramadol?
tramadol in 100 ml NS with emesit.
You should give us a slow infusion over
infusion,
20 minutes.
20
Okay.
minutes. Sample history 45-year-old, non-case of type 2 diabetes, chronic pancreatitis, presented with complaints of epigastric pain radiating to back, associated with nausea and vomiting. He gives a history of alcohol intake few days back before the onset of pain. Pain was severe, which was worsened after food intake and reliefs on leaning forward. And vomiting was mostly food particles. He's also having nausea, so he's not tolerating well orally. No history of fever, cough, chest pain, dyspnea, loose stools, jaundice, constipation. He also gives history of similar episodes in the past. Allergic history, no known allergens. Medication is on OHA for diabetes. Then last meal was since he was not hourly tolerating, yeah, he was only on fluid diet for the past 2 days. Then on examination, patient was conscious oriented. There is no pallor, icterus, clubbing, lymphadenopathy or edema. On systemic examination, CVS S1 S2 present, no abnormal sounds or murmurs. Respiratory bilateral air entry present. Per abdomen soft. Tenderness is present on the epigastric area with a mild guarding. CNS, no focal neurological deficit, no flaps. We did a routine CBC CRP point of care, which shows a mild elevation in total counts of 12,000 and a CRP of 72.1. We also did an ECG to rule out any inferior wall MI, which only show normal sinus rhythm. Since CRP is slightly elevated, we started on antibiotics. And we sent lab lipase, amylase, and UST abdomen was also taken. UST abdomen shows mildly enlarged pancreas, not properly visible due to bowel lobes. And serum lipase and amylase was also elevated. It's in 1,000 ranges. This
Okay, so thus you came to an impression that patient is having pancreatitis. So what is the pathophysiology of pancreatitis?
It's an inflammatory of pancreas. Due to different causes, obstruction, toxins.
Leave the causes. So what is actually happening to the pancreas?
Due to some inflammation, pancreas itself is releasing the proteolytic enzymes inside the pancreas, causing local inflammation inside the pancreas.
So usually the pancreatic enzymes, when it reaches the gut only, it will become activated. So like trypsinogen, trypsin, these conversions and all will happen only after reaching the bowel. But because of some unknown reason, these proteins, the digestive enzyme proteins, everything activation will happen inside the pancreas itself. So that is why pancreas is getting inflamed. So because of that, this your amylase, lipase, everything is getting elevated. So other than amylase and lipase, you can send a urine trypsinogen level. That if it is more than 15, it is considered significant. So it is activation of the pancreas. It can be because of different reasons. So example, causes.
Amylase.
No, causes of elevated causes of pancreatitis. Yeah.
And pancreas, local causes like gallstone. Most important is gallstone. Then
Gallstone usually seen in females.
Obstructed gallstones. Alcohol can cause pancreatitis.
In men.
In men. Then Pro's procedure, ERCP.
Third common cause is unknown. Idiopathic cause. Okay.
Then toxins, drugs can
Toxins like? Many toxins are there. Example like scorpion toxins and all can cause pancreatitis. Okay. Then drugs you have to. What all drugs? Any drugs? Commonly in ER, so you told that you have given paracetamol to the patient. Usually paracetamol is not indicated if it is already diagnosed as pancreatitis, because paracetamol itself can cause pancreatitis in some individuals. Okay. So usually we will discuss about the some drugs which we give in the ER that can cause pancreatitis. Okay. So the one causes paracetamol, that will cause pancreatitis. Then we give amiodarone, like for AF patients, that amiodarone can cause pancreatitis. Then other agents like diuretics, we usually give furosemide, Lasix, as that can cause pancreatitis. Or thiazide diuretics also can cause pancreatitis. Then some antibiotics which we give, like metronidazole, erythromycin, these also can cause pancreatitis. Then some anti-tubercular drugs, antiretroviral drugs, all can cause pancreatitis. Okay. So these are the drugs that might cause pancreatitis. Then other causes. You told ERCP procedure or any trauma related problems like trauma, tumor or any insult to the pancreas can cause. Other autoimmune conditions can cause pancreatitis, or sometimes patient might have had a liver or renal transplant. Such patients will come to RIA. They might be taking some immunosuppressants. That itself can cause pancreatitis. Then one another cause is tumor related hypercalcemia. Hypercalcemia can cause pancreatitis. Okay, these are some of the causes. Then some other causes are infections. Infection means we usually see leptospirosis patients, such patients. So these infections can also cause pancreatitis. So it can be infection, drugs or any other random causes. Okay. Okay, so you have told amylase and lipases increase. So which is more specific for pancreatitis?
Lipase is more specific for pancreas. Amylase can also increase in other conditions like salivary gland disorders. Then any cholecystitis and everything. Lipase is more specific.
Okay. So how much elevation are you expecting to label as pancreatitis?
More than 1,000 ranges. Like
no need of more than 1,000 range. Usually amylase lipase we know the normal range. If the we usually see patients amylase and lipase in 1,000 value, that doesn't mean that patient might be in pancreatitis. So if the lipase is more than 2 times of the normal, that is considered as positive. If the amylase is more than 3 times elevated, that is also considered as positive. Okay. Okay. This patient we diagnose as pancreatitis. So so we know it is pancreatitis. What other test will you do?
We can USG we can see and then CT after 48 hours, or if any complication we are suspecting, we can do a CT. Then mostly pancreatitis is lab diagnosis.
Blood test, what all things will you send?
Amylase lipase.
Amylase lipase we will send. Okay. Then we were told ECG and all to rule out an
LFT we can
LFT to rule
out any stone. Obstructive jaundice.
Obstructive jaundice. Any features of obstructive jaundice can be done by LFT, or any AST elevation, anything can be seen by doing LFT. Then renal function test should be done to look for any infection. This patient is having a high CRP, so infection causing an acute kidney injury. Then
blood
electrolytes.
Electrolytes we can send. In potassium we have to send to rule out any paralytic ileus, which
usually pancreatitis can cause paralytic ileus without any low potassium. Because of the inflammation itself, patient can go into paralytic ileus. Okay.
To look for any systemic complications, we have to take blood.
Any specific electrolyte that becomes low in pancreatitis? Calcium. Why calcium becomes low? Because as we discussed, these digestive enzymes are produced. There will be a saponification which is happening, and calcium will bind to that. Okay. So hypercalcemia can cause pancreatitis. Pancreatitis can cause hypocalcemia. Okay. So calcium should be sent.
Then clotting factors to rule out any DIC or
coagulopathy.
Coagulopathy.
Okay. And CT, you were told CT will be done only after 48 hours if symptoms are persisting. When will you plan for an early CT?
If we suspect any pseudocyst, bleeding, necrosis.
Pseudosis usually happens as once the acute phase is over. So if you are suspecting any obstruction, especially gallstone obstruction or bowel obstruction, in that case only we will be doing in an acute phase. Okay. Okay, so this patient has presented to you with acute onset of pain. You have given paracetamol, but before that, patient is telling patient is hungry, patient is not taken anything. So what will you do first?
Fluid IV. We will keep the patient in NPO.
Yeah, why we are keeping NPO?
Like more secretion. Food can promote digestive enzyme secretion, which can
Food can again elevate the amylase, lipase, all these digestive enzyme production. So that is why we are keeping the patient NPO, because feeding will increase the pain of the patient. Okay. So when will you plan on restarting the feed? Suppose the patient is telling patient is hungry and patient wants to eat food. When will you restart?
After 48 hours, after the patient's patient becomes symptomatically better.
So there is no fixed time. So whenever the patient is able to tolerate, we can start on that. Okay. So but when we are starting, we will be starting as clear liquid diet. We won't be giving much of triglyceride or fatty content, because that itself can cause pancreatitis. So we will be keeping the patient NPO, but we won't be giving a prolonged NPO. We don't want any gastric atrophy or anything. So till patient is able to tolerate, we will be keeping as a temporary NPO. Okay. Then what will you do?
Then we'll start on IV fluids.
Why you are starting on IV fluids?
Pancreatitis can cause, like patient will be dehydrated.
This patient is having vomiting, pain, not eating anything. So that is one cause. Any other cause for starting fluids? Third space loss might be there. Okay. Like a pleural effusion, a left-sided pleural effusion, sometimes ascites can be there. Okay. Any other cause for giving fluids?
Hypotension. Shock and
shock, hypotension and all will happen because of the volume loss. Okay. Then do you have any idea about insensible loss? Insensible loss is usually a patient who is admitted in ward or ICU. Everybody will have insensible loss. Like a sensible loss is a loss which we are able to find out, or which we are able to see. Like a patient is having passing stool, patient is having passing urine. So these outputs can be seen visibly. Or if the patient is sweating, that also can be seen. But insensible loss is a loss of that cannot be seen by us. So especially if the patient is lying down in ward, patient will lose at least 900 ml of fluid as an insensible loss through the skin. Not like sweating, through the skin some fluid will be lost. Or while breathing, some amount of fluid is getting lost. So 900 ml is approximately considered as the insensible loss in a ward patient, and approximately 400 to 500 ml is the insensible loss in a patient who is in ICU. Because ICU patient will be in air conditioned room, so that much loss might not be there. Okay, so whenever we have a patient admitted into ICU or ward, when you are calculating the input and output, we need to always increase the output, increase the input. So because input should be at least 500 ml more than the output. That is to match with the insensible loss. So this, especially pancreatitis patient will be having pain. That time they will be having the respiratory alkalosis anyway. That will lose the fluid. Respiratory loss will be there. So in order to consider the insensible loss also, we will have to give fluids. Okay. What fluid will you give?
RL or NS.
Preferably give ringer lactate. Why? Why not NS? NS is what? Sodium chloride. This chloride can again activate the trypsinogen to trypsin. So it will again worsen the pancreatitis. So in a pancreatitis patient, keep a NPO and start on ringer lactate more than a normal saline. And for pain,
tramadol.
Tramadol. So as we told, paracetamol we won't be using because it might cause pancreatitis, and treatment of choice usually we prefer only opioids in case of pancreatitis to reduce the pain. Okay, and any opioid which we don't consider, we know opioids which we usually use are morphine, tramadol, fentanyl and all. Any opioid which we don't use? Morphine can cause sphincter of OD contraction can be there. So we can give tramadol. Tramadol MSIT can be given. Okay. And this patient antibiotics was started. Do you think antibiotic
is not indicated? It's an inflammatory process. Antibiotic, it's not an infection.
So when will you plan on giving antibiotic?
When there is a secondary infection. Or CRP is elevated.
So CRP might be increased. CRP is an inflammatory marker. So CRP will be increased in pancreatitis. So if any fever or other systemic infection, if you are finding only, you will be giving antibiotics. Okay. Then we have told about fluid resuscitation. How much fluid will you give?
20 ml per kg fluid. 3 ml.
A patient ideally requires 2.5 to 4 liters of fluid. That should be corrected over 48 hours. Okay, so suppose you are planning to give, patient is young, patient is stable, you can give fluid boluses. So when will you consider not to give much fluid boluses?
CKD or CAD patient.
Okay, that is correct. CKD, CAD patient, we don't want aggressive fluid resuscitation. We don't want patient to go into pulmonary edema.
Any system like fluid ascites or pleural effusion or any fluid restriction.
So in a pancreatitis patient, we can give liberal fluids, except in case of pancreatitis causing an ARDS.
Yes.
So if the patient is in ARDS, respiratory distress, and clinically if you are suspecting ARDS, we have to match input and output. So in that case, we won't be giving a lot of fluids. Okay. So that should be noted. So before putting on NPO, we need to think whether this patient actually requires NPO or not. Before starting fluid, we need to think whether the patient requires fluid or not. Any contraindications of fluid, if at all contraindication anything is there, we will have to plan on a liberal fluid, restrictive fluid strategy. And what fluid to be selected, that is ringer lactate, and analgesics also, and antibiotics only if it is required. Okay, so what all are the complications of pancreatitis?
There are local complications and systemic complication. Local complication mainly pancreatic necrosis or peripancreatic fluid collection, and systemic complications can be ascites, pleural effusion, SIRS, then multi-organ failure can occur.
Okay, so near the pancreas there can be inflammation, necrosis, pseudocyst pancreas, these things can be there, and other than systemic, abdominal complication itself can happen. Because of the inflammation, there can be bowel obstruction, then there can be hematemesis, upper GI bleed might happen, and bowel necrosis can happen. These are the abdominal complication. Then comes the systemic complications. Okay, so if at all we are suspecting clinically complicated local pathology only, we will be planning to do a CT abdomen. Or if you are not getting any cause for the pancreatitis, then only we will be planning to do a CT abdomen. Okay, then what happened to this patient after that?
After fluid, we keep NPO analgesis. Patient become better and also
admitted
under GA medicine for further evaluation and management.
Okay. Anything else you have to add? Okay, so along with that, with the blood test, in order to do the scorings, the worsening scoring, we will have to always check for the hematocrit value, LDH value and all, for the Ranson scoring, and that we will discuss later. Okay, thank you.